Thank you for joining us today, Doctor. Over to you. You can start.
Thank you. To share the screen now.
Yes.
Shall we start, sir?
Yes, Doctor.
Yes. Good morning to all present here. Today, myself, Dr. Veerasankar. Today, the topic of discussion is on case selection, treatment planning, and the patient engagement for clear aligners. It is about enhancing the treatment excellence. Moving on to the introduction, individuals pursuing orthodontic treatment are demonstrating a growing preference for aesthetically discrete options as they seek to avoid the visible appearance of orthodontic fixed appliances. So this has produced a demand for more aesthetic options. There comes an aesthetic thermoformed appliance that represent as an option in the treatment of malocclusions. Despite the growing popularity and its use even in the complex cases, question still remains concerning the proper use of this technique and its limitations due to the characteristics of the material and the thermoforming process, which in specific cases can limit or even make the use of clear aligners very difficult. So the purpose of this presentation is to have a discussion on the case selection, treatment planning, and how to engage the patient for clear aligners. So moving on to the history, Dr. Dean Kessling in 1945, he introduced a tooth positioner. A tooth positioner was a rubber appliance fabricated on the idealized wax setup wax used to position the teeth in an aesthetic manner and to retain the alignment of the teeth achieved through basic treatment with the conventional fixed appliances. Later in 1971, Ponitz introduced an invisible retainer, which was formed using a thermoformed acrylic sheet. Later in 1993, a sixth retainer was introduced, which was made up of a thin, clear sheet of material that snap fits over the dentation. So moving on to clear aligner therapy, it is of two common classifications. One is the Essex system, which is basically a displacement-driven system. The next one is an INVISALIGN system, which is a force-driven system. So moving on about discussion in detail about these two systems, I'll just mention about the steps before we decide about the method of choice of treatment, like it may be an Essex system or an INVISALIGN system. This entire steps is formed for both appliances. So the steps involved is pre-appliance requirements, taking the patient records, planning a proper diagnosis and treatment plan, record submission to the aligner providers, and thereby followed with a 3D computer modeling where we can accurately plan the treatment. And after the planning is done, the plan is sent to the clinician for reviewal, and they can approve it, or if there is any modifications, they can revert back to the lab. Once the doctor approves the plan, they will go ahead with the manufacturing of the aligners. See, before approval, anything can be changed. But once the case is approved, the entire set of the aligners will be fabricated, and there's no point in going back, and they will actually ship the aligner, and they will go ahead with the billing process. So before approval, or before telling go ahead with the approval to the lab, we should ensure that it has been properly discussed with the patient, and we have got enough concern and even the lab choices with the patient. So moving ahead with the pre-appliance preparation. Prior to initiation of the treatment, all necessary restorative treatment should be completed. And an important prerequisite is that the patient should not exhibit an active periodontal disease. So what is the necessary restorative treatment? Before even proceeding with them, scanning, when a case comes for an aligners, we have to complete all the restorative procedures, even if it may be a small fillings, or if you suspect a teeth may go for a root canal treatment in future, better to complete the root canal treatment now and followed up with a temporary so as to proceed treatment. We have to maintain the mesiodistal width of the teeth. So in such case, if the tooth have been already grown for root canal treatment, more chances any one of the one, either proximal or buccal or palatal one, would have been fractured or it has been lost. So in those cases, if we go for a crown, it will be better for us to maintain the mesiodistal width. Then why it is only the temporary growth? It is because during orthodontic treatment, we'll actually incorporate movements in all three planes of space, that is vertical, transverse, and also sagittal. So in such case, there is more chances that the position of the crown may vary. It may go gingival, or it may extrude, or it may move in the vertical plane. More of a chances. So the crown fit may change. So that is why we just advise them to go for a temporary crown. After the treatment, we can go for the next step is the pre-treatment records. Like in comprehensive orthodontic treatment, the complete evaluation of the patient is advised as we do in the fixed oral case, which involves a pre-treatment photographs of frontal and cushion, spine, profile, and the oblique view, and 5 sets of intraoral photographs. Followed up with the lateral patient. So we have to analyze the records properly, arrive at a proper diagnosis, followed up with a proper treatment plan. The treatment planning may be an option 1 or 2, depending upon the patient's convenience. Like we can either go for a straightforward plan, or if the patient is not willing for that plan, you can have a choice 2, which is a camouflage plan. So, main thing is informed consent should be obtained from all the patients before the treatment even begins. That should involve either it is an extraction of push or an extraction of push, IPR in these regions, and either the treatment enter option, how much amount of duration the retention should be there. And even if you advise them to go for a third molar extraction during treatment or after treatment, that also should be mentioned in this form. And the written consent should be obtained from all patients. So moving on to the process, the first step is when the patient is okay for the alignment, we have to take either a good previous impression or an intraoral scan. This should be sent to the lab. They will work on the entire previous impression or the digital models. They will slice the teeth, move the teeth individually, and they will plan particular treatment with an appropriate sets of aligners. They will send the plan back to the clinician for approval. Once we have approved it, they will print a 3D models which will be used for fabrication of the aligners, and the aligners will be sent to the patient. So, any patient who walks into the clinic inquiring about the clear aligns, the first step to proceed with is intraoral scan. I request all our doctors to go ahead with the intraoral scan, even the patient is willing or not, because only after the scan we can show the patients their entire position of the teeth in all 3 planes of space, so as to visualize what are the problems that is there in them. So in certain patients, there will be severe rotations of the posterior teeth, asymmetrical position of the posterior teeth, meaning the right side molar will be in class 1, the left side molar will be in or class 2. Sometimes they require lower mesialization or upper distalization so that we can achieve the symmetry between the arches. In those patients, without any reason behind that, they will be chewing unilaterally. Only if we do that proper examination with the help of this intraoral scan, it will be easy for us to explain the patient about their bite, whether it is open bite or it is deep bite. Why this treatment is indicated for that particular patient. Everything can be shown with the help of intraoral scans. So it is mandatory for go ahead with an intraoral scan when the patient walks into the clinic for the first time, inquiring about the labels. Moving on to the second step is something called as outcome stimulator. See, I have ITO, so I have taken this as a screenshot. But our clinicians who are all in the call, they might be aware that who are having the scanners with them, there is something called as outcome stimulator, which will be given as a software freely provided by the scanner manufacturers for any patients when we do a scanning. AI-induced outcome stimulation can be shown within few seconds. See, for example, in this case, it is of severely proclaimed upper and the lower anteriors, the spacing on the anteriors. So here, the AI-induced treatment stimulation is done within few seconds. So it is easy for us to show the stimulation in the same patients now, how the treatment is going to appear, how the teeth is going to appear after the treatment, like the spacing is closed in the midline region, proper intercustation is achieved, proclination is being corrected, and canine relation, molar relation, good proper intercustation, etc. So it is an easy tool for us to convince the patient because they are just seeing the changes, how the treatment is going to be in the with their own dentition, they are going to visualize during at the time of scanning itself. So this will be easy factor for us to convince the patient. Number 2, however, this is only 60 to 70% accurate after our treatment plan. you should rely only on the treatment plan which was provided from the lab, because this is only AI induced. So that plan will be more accurate. Also, it shows us how much number of aligners is required to achieve that particular treatment. So, going on to the sixth system. This system uses the skill of a dentist in the fabrication and realization of the treatment objectives. It's fabricated with the help of a thin, durable, thermoplastic material that is practically invisible. So the SH system can be used to bring about minor tooth movements in all planes of space. Whenever the tooth movement is planned using a thin plastic appliance, provision should be made for the application of forces, and also a space should be planned in the appliance in the direction of moving teeth. For example, if a tooth is moved palatally, force should be applied by the appliance on the labial aspect, and the space should exist on the palatal aspect of the appliance for the tooth to move palatally. So, at this point, the system scans the raster models for various impression or interval scan, and it develops a 3D presentation. It separates the teeth, allowing them to be moved initially, and places them in their virtual aligned position, thus stimulating the axis. Tooth movements are staged in order to avoid the interproximal and occlusal interference. What's that staging of tooth movement? In orthodontics, there is something called as round tripping. We usually, when the patient comes with a proclination, the round tripping is nothing but moving the teeth forward and then taking it back. What is that forward moving? Is it really necessary? Yes, in certain cases. When we plan for an aligner treatment, usually most of the method of gaining space will be an IPF, because we used to gain 4 or 5 millimeters with the IPF that can be managed, can be utilized as a space required for correction of the alignment or proclination. So in those cases, the regions where the IPR is being planned, if those regions are inaccessible, you can stage this IPR later on, like during the time of after 7th aligner or 6th aligner, like that. You can stage this IPR when you get the proper access. So it will be easy for us to avoid any iatrogenic effects. So coming to the stages required, this stages means that it depends upon the complexity of the treatment. What is this? So in a case with a functional interference, like anterior teeth being in prospect, when the patient opens and closes the mouth, most of the time it will bring the mandible forward. It is called as functional shift. That is, when the patient tries to close the mouth, after the first tooth coming into contact, there will be shift in the position of the mandible. So in those cases, actually, it is difficult for us to arrive at the proper position of the mandible unless or until we correct this functional interference. So in those cases, what we do is we will do in a staged manner of treatment. The first phase involving only correction of this crossbite and bringing the mandible into control. So later on, when the mandible arrives at a particular position after the correction of crossbite, where the canine relation and the molar relation ends, that is again, we have to restart the treatment in a phase. So it is called a staged treatment. So how many number of stages depends upon our treatment objectives and the complexity of the treatment. Tooth movement that is happened with the aligners will be about 0.2 to 0.3 mm per aligner, and the duration of each aligner will vary from 7 to 14 days, depending upon the aligner quality. So the possible treatment tooth movements happening with the aligners for posterior expansion, anterior retraction or protraction, molar uprighting, distalization, anterior root torque expression, or a combination. So when the orthodontist has proposed a treatment plan, the series of aligners will be manufactured. Each aligner is laser engraved with the patient details like aligner number and arch, either upper and lower arch, for identification. They are then disinfected, packed, and shipped to the orthodontist. So this is an example of an aligner. This patient comprises of 42 aligners, out of which this is a 35th set. So can you see here, it is a laser engraved with the details. This is a lower set of 35th, and here it is mentioned as upper 35th. So coming to the inducing of tooth movements with the help of an appliances, there are two methods when we induce forces to the tooth through the aligners. One is creating a spot in the aligners. The next is creating a notch on the working movement. All this will be done by the lab. Technique 2 is either placement of attachments. That is nothing but creating a projection. Moving on to the next system is an INVISALIGN system. Introduced by 1997 by the Align technology. It is a CAD/CAM technique. It uses a series of questionnaires to move the teeth. The system revolutionized the use of clear aesthetic plastic analysis. They have different categories of patients coming under adult, teen, and child. They used to manage the pediatric patients like arch expansion can be done, anterior tooth interference, and single tooth crossbite, multiple tooth crossbite, and growth modifications like mandibular advancement can be done, and rapid maxillary expander can also be done with an INVISALIGN analysis. All this comes under a separate category. Starting from a number of aligners, they have a different category, leading to a comprehensive pack of 5 years validity with unlimited number of aligners. So moving on to the topic of interesting case selection. Who are the ideal candidates or indicated candidates for aligners? The patient who has a deep overbite problems, which are non-skeletal in nature. The cases of constricted arches, which is only dento-alveolar component, which is not only dento-alveolar component. In the case of mild relapse after fixed orthodontic therapy, mild to moderate occlusions having anterior crowding or anterior spacing, mild space closure, limited dental expansions in the incisor advancement, and limited dislocation. Moving on to the contraindication, it depends upon the malocclusion severity, crowding or spacing exceeding 5 millimeters, anterior-posterior discrepancy greater than 2 millimeters, malocclusion requiring mandibular advancement, and the class C malocclusion requiring maxillary protraction. COC are discrepancies with skeletal deep bite, skeletal open bite, the teeth requiring severe exclusion and severely tipped tooth, that is class 2 division. Cases with a short clinical crown because engagement of the aligners over the crown will be difficult, and cases with a multiple missing tooth where the anchorage control and predictable movements are compromised. These all the limitations and the indications are placed for conventional aligners or normal physics or displacement driven aligners. When it comes to INVISALIGN, all the contraindicated is ruled except for this in the class 3 cases requiring maxillary protraction. So whenever the patient is growing, we can encounter two malocclusion, class 2 and the class 3. Class 2, if the mandible is retrognathing, should be advanced, can be done with an aligners with the help of mandibular advancement. In a class 3 cases, when the maxilla is to be protracted, the ideal option is the face mask therapy along the expansion. It can, those cases, is the only contraindicated indication for clear aligner therapy. Class 3 growing patients with a maxillary retrognaths requiring a maxillary advancement correction, growth issue. The same patient, when they report to the clinic after the growth is being completed, they can be managed with the alignments, but with different protocols. And depending upon the severity, the treatment plan varies. So now moving on to the topic of how the clear aligners going. As I discussed before, there are two common mechanics. One is the displacement driven, force driven. In displacement driven, all the ASIC system works under the displacement driven. That is, series of models is printed as per the planning of the software. Mild movements like tipping can be occurred. When it comes to a force driven, complex movements can be achieved because we are applying biomechanics principles. On complex repositioning is also possible. So, aligners designed to advance software exert controlled forces on the teeth, and their shape can be altered using pressure points or power edges. Attachments further enhance the system, allowing for intricate movements like extrusion, rotation, and root control. The incorporation of tabs in conjunction with the aligners has expanded treatment possibilities. So, moving on to the biomechanics, aligners are digitally designed using advanced software to exert control forces on teeth. Their shape can be strategically modified using pressure points and power edges. They have attachments that is nothing but a small tooth-colored composite additions bonded to the teeth that further enhance the aligner's effectiveness, enabling complex movements such as extrusion, rotation, and torque. In a more advanced cases, that is severe cases, the use of tabs in combination with the aligners has significantly expanded the range of treatable malfunctions. Moving on to the aligner biomechanics, when compared to the fixed appliance, the clear aligners exert a push force in the teeth. Coming to the engagement of the appliance, it is a plastic around the teeth The more plastic wrapped around the teeth, the better engagement is. Moving on to the anchorage segments can be predetermined when it comes to clear aligners. So inclination and the vertical control of the tooth have an excellent control when compared to the fixed lines, and the midline correction is more predictable with clear alignment. So there's something called as Volten discrepancy, which we use to analyze the model analysis. If there is any tooth material excess or deficient, the patient present with a spaced dentition, it is because of increase in arch size or decrease in tooth. At the same time, the patient comes with an excess crowding of the anteriors or posteriors. It is because of decrease in the arch length or increase in the tooth material. That can be assessed, and it is a valuable tool in planning the treatment. So those Volten discrepancy can be assessed with the help of this software, which will help us to plan the treatment in a more accurate. Moving on to the force. So as we discussed before, push force is a method of choice for clear aligners. When an aligner is inserted over the teeth, there are minor differences between the position of the teeth intraorally and the position of the teeth in the aligner. So the aligner deforms over the teeth, and the elasticity in the aligner material push the teeth into the new position. Optimized attachments provide an active flat surface that the aligner may push against to provide a good purpose. So aligners offer an extremely good control of anchorage because anchoring teeth can become immovable at different stages. Can you see the images here? Here, the tooth movement happening is only on the second molar. It is at the type of movement is distalization. So only the second molars are displaced in the manner of sequential distalization, in which during the initial stages of movement, the remaining teeth in the arch form from the first to the first molar on one side to the other side. They will act as an anchorage segment and used to push the molars distally for anterior-posterior connection. These are all the different types of attachments: buccal power bridge, optimized attachments for rotation, extrusion, intrusion, deep bite attachments, pressure areas, anterior bite ramps for deep bite detection, anterior intrusion, and they increasing the posterior anchorage in the premolar region so as to provide anterior intrusion to help the functions. Moving on to attachment placement. When the during the attachment placement, the aligners and the attachment template is the first step is you have to check with the placement of the attachment template. Then isolate the cheek retract and prepare the teeth. Apply tension for 30 seconds. Wash the surface of the teeth carefully and then dry until the surface of the teeth becomes completely white. Use the bonding on the surface of the teeth and cure it following manufacturer's instructions. Apply the composite roughly in the attachment template. Then place the template in the mouth and apply pressure while curing the template attachments. So remove the template or remove excess composite with the burr. Then go ahead with first fit the aligner. See, what I personally do is before placement of this attachment, you just deliver the aligner. Ask the patient to remove and insert the aligner again. Let them use for 1 week because aligner being a plastic material, it will be very stiffer for first few days. So soon after the placement of the attachments, the aligner will become more stiffer, difficult for the patient to remove and insert. So in my practice, personally, I implement a method that I will deliver the aligner on the day one. I'll recall them on day 8 to place the attachment. So by the time the patient will be very comfortable and got used to the aligners in the day-to-day life, like they will be comfortable in speech world, and the practice of removing the aligners during having anything hot or cold or while having foods and brushing, everything will become normal. And the speech would have been accustomed to the placement of aligners. And now, when I go for a placement of attachments, the same aligners will be slightly tighter than. So this is what I personally do. So after the aligner is being fit, the active dwell of the attachment must be in contact with them. We have to ensure that. Repeat the same process in the other arch. Show the patient how to insert and remove the first aligner and personally support them for the initial few aligners, like at least 4 aligners. Moving on to the patient compliance, which is an important factor in any removal. So patient motivation and compliance are essential for successful treatment with removal appliance, like removal clear aligners. Aligners must be worn for 20 to 22 hours per day to be effective. They should only be removed while having meals, drinking hot or sugary beverages, and during brushing and flossing. Because aligners are removable and transparent, they can easily be misplaced and forgotten. Therefore, strong patient commitment is crucial for achieving the desired treatment outcomes. Moving on to the advantages and limitations. The advantages, as we all know, it is very aesthetic and comfortable for the patient. Since they are removable, it is easy for the patients to maintain a good oral hygiene. It requires very fewer clinical visits because everything is pre-planned. So, digital treatment planning allows the clinician to provide a more ensured and very practical and predictable results and avoiding an anticipated problems. Moving on to the limitations. Since it is a removable appliance, patient compliance is very much required to achieve the desired results. It is less effective for severe malocclusion when it comes to a conventional aligners. And attachments may be necessary to make the aligners work in a more effective manner. When compared to the braces, that is conventional braces, clear aligners are more invisible and removable. There is no special technique or thing should be followed up when they go for a oral hygiene maintenance. No change in eating habits. Like conventional aligners, they have to have they will face difficulty in eating, and they have to have some dietary restrictions when it comes to fixed braces. Here, there is no change in dietary habits. Very comfortable and convenient for the patient, requiring very minimal appointments. Aligners lack the brackets and wires associated with the fixed appliances, so it will minimize the oral irritation and discomfort. It is highly indicated for a patient who is very busy seeking orthodontic treatment. Less discomforts and fewer emergency visits. Unlike in fixed appliance, they will come with a wire poking or broken braces. This usually requires a very fewer person appointments. And this predetermined treatment plan that requires fewer monitoring visits. So the integration of CAD/CAM manufacturing enhances treatment predictability. Clinicians can accurately forecast the course of treatment, providing patients with a clear understanding of the expected outcomes and timeline. So, aligners not only deliver an aesthetic improvements, but can also address the functional issues associated with the malocclusion. This is a case of a patient who comes with an anterior traumatic bite. Whenever the patient opens and closes, there is a traumatic occlusal interference on the anteriors. There is trauma of the anteriors. This particular option in an intraoral scan help us to visualize, show the patients how the anterior teeth are traumatizing the lower anterior teeth is traumatizing the upper anterior teeth and the need for its correction. So what we will do is we will upright the retroplaned incisor, achieve an ideal overjet and overbite so as to relieve the incisal trauma. So if that is not done in the right time, it may lead to the incisal attrition. Later on, this entire anterior teeth will lose its crown height, leading to a prosthetic rehabilitation. Even then, if you go for a prosthetic rehabilitation, it will be difficult for our clinician to go for a proper prosthesis because the TFO is from the upper anteriors because of the faulting position of the anterior teeth. So this interference can also be shown in a color-coded method with the help of scanned images. So after this correction, improvements must reach, showing efficiency and overall oral function as teeth is improved as the teeth are guided in more optimal positions. Now, moving on to the limitations. We purely depend on patient complaints is the limitation, and we have to motivate them and train them to wear the appliance 20 to 22 hours per day, which is again a very difficult process, and it's expensive than the traditional braces. In a growing patients with a class 3 malocclusion and in patients requiring orthopedic correction like face mask therapy, it is contraindicated. So moving on to the 3D computer modeling. Soon after the scan reaches the lab, they will come out with an initial plan, which can be corrected by us, the clinician, like minute modifications can be done. Or if it requires a severe modification, it can also be getting assist from the laboratory orthodontist who design the treatment. For example, I'll show you this treatment plan is requiring anterior intrusion and alignment correction. there is IPR in the anteriors, and the most you can observe that it is when and staged IPR happening at different stages of treatment. That is during the first aligner and fifth aligner, 25th and 28th aligner. Like this. Soon after the access is achieved, they are going for the IPR. And when there is a need for the teeth movement being retracted, they go ahead with that. What is this color coding? It's nothing but it is out of the range. For example, if the inclusion is only expected inclusion of the dullness is only 2.5 to 3 millimeters, if it is even 3.01 millimeter, it will be in a different colored manner. That's it will become a black. So this is color coded. Next one is this is a case I was discussing about when we plan it digitally, we can avoid problems being anticipated in a pre-air because of the tooth being moved to the ideal position, which is not possible with conventional approaches. So in this case, it is an aligner case, crowded and spaced anteriors. When we approximate the teeth, the space closure in the anterior segment, we face two problems. One is the lower teeth hitting the upper one. Number two was then black triangles that is formed between the incisives. So what I have done is this we used to follow in the routine fixed plans also, but it's not possible for us to predict that in earlier time. So, for example, if this is a non-extraction case and does not require any IPR with a fixed plans, and if I'm attempting the same case after the leveling and alignment is completed and the space closure is done, the patient end up with a black triangles in the anterior region. So that time, when we try to explain them, this is a black triangle and the teeth needs more approximation and needs IPR. The patient might not, sometimes we feel reluctant to go ahead with the IPR because it has not been told in the earlier. And it still complains that the space is not closed. The space is there between the teeth. But to be frank, the teeth has already approximated in the midline region. This is black triangle. So here, when it comes to an aligner, after this approximation, I have planned in ahead that IPR should be done in the midline region, which will reduce this. This is the advantage of applying predictable results. And number two, after immediate adding up of the IPR and receiving changes in the number of aligners and changes that can be visible in the overchit and overbite compared to the initial and after the changes being incorporated can be visualized so as to plan the treatment in a more effective and efficient way. So after the clean check, modifications can be done or requested. Soon after the plan is approved, they'll go ahead with the aligner fabricating and the aligner should be shipped to the clinician. Once the aligner is received, you have to deliver the aligners after potential. So moving on to monitoring the treatment. So when it comes to an aligners, the most frequently asked question from the clinicians to an orthodontist is, I don't trust this process because we are unsure whether the patient is properly wearing this aligner, whether it is working or not. Do they really work? These are the most anticipated questions or frequently asked questions. Yes, we can monitor the treatment. How? We can recall the patient once in 3 months or so as to check the position of the occlusion related to the clean check period. And we can check for the fitting of the aligner over the teeth and whether if the fit is proper, nothing to worry about because the tooth movement is tracking as per the aligner plan. So at least it is mandatory to go ahead with a review of this aligner patients once in 3 months or 6 months, okay, if possible. So I said, yes, this treatment monitoring can be possible. Yes, it can be done in a digital manner also. You can look at the video. See, there is something called as progress assessment. So any patient going for an aligner treatment, if they are visiting you after 3 months, this is available with an ITO and INVISALIGN planning. There is something called as progress assessment. We have to do a regular scanning, intraoral scanning, and we have. Can you see here in this video? To show you. So this is a patient having a 66 aligners. So now they have completed 35th aligner and walked into the clinic with the same scanner. We have to do something called as progress assessment scan. After the scan is being completed, it will be actually merged to your original treatment plan, with which the entire process, the software itself will tell us with the color-coded images over the teeth surface. If there is a yellow color, it means the movement of the teeth is not tracking clinically to the plan. When it is this gray color, it means no significant movements or that is being modified. And when it is in violet color, it means the treatment movement is happening opposite to the plan. If it is in the cream color, it shows that the plan movement is happening as per our original plan. This can be done. This is called as progress assessment scan. Can be done at any time during the aligner treatment. It will be actually projecting the current position of the teeth and to the aligner number, which will be matched to the original treatment plan. So if there is any discrepancy, that can be rectified either by stepping down the aligners or doing a rescan and fabricating the new aligners. Both processes can be done. It is called progress assessment. So if the teeth do not seem to be tracking well in the aligners or treatment needs to be modified, some type of mid-course correction may be necessary to revise the original plan or augment it with slightly modified aligners. So that's understanding the attachments and IPR. So in certain cases requiring more extrusion or rotation bodily movements, I request you to go for an attachment placement. Like which was a rectangular or bevel or ellipsoidal attachments. IPR required in the cases to reduce the black triangles as we discussed before. In a case where you encounter a poor enamel quality, I advise you to not go for IPR. So we'll discuss about the cases before and after images. I personally wanted to tell you that I am not sharing the extraoral images of the patient because I have not obtained the consent for projecting those extraoral images. So here I will show only the intraoral images of pre and post, and I will discuss about what's the plan that have been done for the patient. So case 1 is a retreatment case. This is a case of a patient undergone all first premolar extraction for anterior retraction 5 years back. But this is a surf-and OPG they have brought to me while visiting the clinic. You can clearly appreciate that increase in inclination of upper and the lower anteriors and increase in the and fully erupted third molars and extracted first premolar. So this is the proclination that is there in the patient's mouth. So now they doesn't want to go for a fixed appliance therapy. So this is a case of all first bicuspid extraction. So what the treatment plan suggested by myself is to go forward with the fixed appliance therapy, extraction of all third molars, then placement of skeletal anchorage systems like infrazygomatic crust screws and the buccal self screws, so as to dislice the entire dentition backwards, upper and lower, in the place of a third molar after extraction. So the patient was reluctant to go ahead with the fixed appliance therapy because they had a very worst experience with the fixed appliance, too much of discomfort. The only thing they want is something to be rectified in a simpler manner like aligners. They prefer Invisalign. So what we have done is with the same Invisalign, we look at CBCT. We have applied something called as sequential distalization. As we discussed before, it is nothing but holding all the teeth from the first molar to on one side to the other side. We will hold it. We will not initiate any tooth movement. We use this as an anchor unit to push the second molar distally for anterior-posterior correction. This is a CBCT integrated intraoral images of the same patient. After the third molar extraction, we have started with a purely an distalization option because the third molar is fully erupted. On analyzing the CBCT, there was a sufficient room for distalization of the anteriors to that particular position. So we have initiated distalization as a method of choice for space cleaning to take the anteriors or to retract the anteriors. Patient is very much satisfied with the finish of the treatment. We have done only 3 mm of distalization. Patient is very much happy with the treatment. He can add 35 sets of aligners. This is a pre and post OPG comparison. You can see the uprating incisors. So moving on to the second case, this patient reported to the clinic with an ongoing fixed appliance. Her complaint is, you can see here, this upper midline is shifted towards the right. I said it is because of the retraction that is happening on the right side is faster when compared to the left side. Now the patient said she wanted to continue the treatment, but the problem is she got married and going to Australia. She can visit India only once in a year. So I suggest him to go for an aligners. After the aligner treatment has been initiated, this is after 8 months. The space has been closed completely. The midline shift that was complained by the patient is corrected. She was very happy because the treatment was very much satisfied. because the treatment was completed without any disturbances or discomforts, and it was very fast. And she had visited here only one time after the treatment was initiated. She is very much satisfied. So this is the pre and post intraoral images, that scans being compared. See, with the IT row, all the scans being taken will be exported as images of all sides, like right side, left side. The intraoral images that I have told as a prerequisite of sites of the treatment can be exported with the scans itself. It is a software. So it is not necessary for us to crop those images. Going on to the class 3 of growth modification. This patient reported to the clinic again with a class 2 mandibular retrogrades. The suggested treatment plan was to go ahead with a mandibular advancement because the patient has is only in the cervical vertebral stage 2 with 65 to 85% of the growth left over, and we send for the twin block advancement therapy because the anteriors of the lower jaw is impinging the palatal mucosa. It is a severe deep bite and traumatic bite, but the patient is traveling to abroad, so they are reluctant to go ahead with the twin block therapy, and the patient was not convenient with the conventional twin block therapy. So we have suggested them to go ahead with the clear aligners along with them in mandibular advancement. And it is a comprehensive 5 years package. They was visiting India once in a year. So this is initially after the correction. Now there is something called as eruption guidance, with which, since the patient is in a transitional stage from the mixed dentition to the permanent dentition, there is one option called as eruption guidance, in which if the deciduous molar has lost or there is no space for the there is space is only left over because the exfoliated molars leaves space there. There is something called as eruption guidance, which will provide space for the premolars to come into the arch in that particular movement. The rest of the space will be utilized for that moving the teeth. Okay, so that is something called as eruption guidance that was also incorporated here, and we could able to correct the mandibular advancement comfortably for the patient visiting the clinic once in a year. Moving on to the next case, mutilated dentition. This patient reported with a crossbite on the posterior teeth and also anterior teeth. This 2-3 is informed with the retained space canine on the left side of the upper arch and extracted molars and mesilated molars. He was reluctant to have fixed appliance. Moving on with the clear aligners. This is after 5 months of treatment. We can appreciate the transverse correction over the images taken in a 2-3 months interval. This is after the 3 months. This is after next 3 months. Okay? We could able to correct the crossbite. Whereas in the same case, if it has been attempted with a fixed appliance, it is necessary for us to create a space first for bringing the 2-3 buccally. Number 2, we have to rise a bite either with the help of a bite plane or posterior bite ramps or anterior bite ramps or something like that, which will definitely have a disturbance in the day-to-day activities of their life. And they will have an occlusal disturbance also. The patient will not be able to eat properly. Whereas when it comes to an aligners, this bite ramps, everything was incorporated inside the aligners, which could effectively move the teeth. At the same time, the patient's quality of the life was not affected without any functional disturbance or patient disturbance. The patient is really happy about the treatment, and it is an ongoing case. Moving on to the last case of discussion is nothing but a case of mandibular retrogradism again. But there is something called as functional retrusion. A term functional retrusion, commonly encountered in orthodontics. It is also related to a principle called as foot and shoe reference. So this foot is mandible and the shoe is maxilla. So whenever the maxilla is broader, that will allow the transverse, vertical, and sagittal movement of the mandible or growth of the mandible. If it is constricted or retruded, that will definitely have its impact on the mandible. It will not allow the mandible to express its normal growth. That is called as foot and shoe reference. The next one is functional retrusion. Whenever the anterior teeth of the upper jaw is not in a proper position or retrocline, or if it has a crossbite tendency, it will definitely have its implication in the mandible, like it will close the mandible or lock the mandible. It will not allow the mandible to move forward. That is called as functional retrusion. In those cases, when it comes to a braces or when it comes to an orthopedic or myofunctional appliance, what we will do is something called as pre-functional appliance, wherein we will bond the entire anteriors, even though if it is in a mixed dentition case, we will correct the inclination of the incisors so as to create the sufficient overjet for the mandible to come forward we will actually assess whether it is happening on its own or we need to do guide the mandible forward with the help of any other appliances. The same concept have been applied in this case where we have actually initiated only the alignment of the anteriors till the 26th aligners, both in the upper and the lower jaw. Soon after the alignment is completed, the next 26 aligners involves only the mandibular attachments. So here again, the IPR is planned in a staged manner. We are just expanding the arches gradually, aligning the ideal position of the incisors and the inclination of the incisors. Later on, soon after the alignment is completed, in stage 26 to 56, we are just going ahead only with the mandibular attachment. This 56 is actually including the retainer of 15 sets because after any correction, even at endoalveolar or skeletal, it tends to relapse at least 10%. We are just avoiding the relapse with the retainer being incorporated inside this aligner therapy itself. This blue color image is nothing but it's the precision rings used for mandibular advancement along with the clear aligner therapy. So when the treatment is completed, the patient has to go into an active retention. It is indicated for all patients. The final aligner should not serve as a long-term retainer as the material is not durable as other available retainers. An invisible retainer can be an excellent choice after the active phase of treatment. Coming to the retention strategies post-treatment. Why retention is crucial? Teeth have a tendency to relapse. Aligners don't change the soft tissue adaptation. So fixed retainers bonded wire for the long-term stability is advised, or else removable retainers like Essex retainer or Vivera retainer or Hollis retainers advised. Or hybrid retention plan with a fixed retainer on the lower and removable retainer on the upper is also indicated. You can discuss and decide about the pros and cons of these different retainers and plan about retention. It is very important. What are the common mistakes and how we can avoid them is poor case selection and poor treatment planning with improper treatment objectives, lack of proper attachment placement, inadequate patient compliance and monitoring, not accounting for retention and relapse. So what are the solutions? Proper treatment planning and the patient education is important, and regular follow-ups and refinements may require, which will be a solution for the problem. On the long-term retention with the retainers, maybe Essex or Vivera is a method of choice to avoid the relapse. So the last topic is root resorption with the clear aligners. As we all know, root resorption is a well-recognized complication in orthodontic treatment, most commonly associated with fixed appliances. These systems can generate excessive pressure in the apical region, leading to external apical root resorption. So the evidence from the literature states that fixed appliances are more frequently linked to root resorption due to continuous and often heavy pressures applied during treatment. In contrast, the thermoplastic aligners and their impact on the root resorption is very limited. Systemic reviews state that only 3 eligible studies included. They concluded that clear aligners can cause root resorption, but incidence and the severity are lower compared to fixed appliances. The resorption is typically less extensive and it is less aggressive. Going on to the frequently asked questions when it comes to an aligner treatment. Can clear aligners be used to treat all type of orthodontic cases, or are they limited to specific situations such as only midline diastema, spacing, or extraction cases? Yes, clear aligners can be used to manage all cases, provided what is your method of choice and what is your treatment objectives. Method of choice in the sense either it comes under a force-driven aligners or displacement-driven aligners. That decides whether all your objectives can be completed in the treatment or not. Number 2, if your objective is simple, you are not worried about the posterior or derotation or posterior crossbite correction or something. You are only focusing on the anterior social 6 mile because patient wants only that. It can be corrected with the simple aligners like displacement-driven mechanics. If you want a complex treatment, then better go ahead with the force-driven mechanics. So next question is, how can we effectively convince a patient to choose a clear aligner therapy over traditional braces, just explain them about the advantages and the comfort of clear aligners. What are the drawbacks of the fixed appliances like every monthly visits, discomforts being generated with the help of because of the broken brackets or misplaced wires. Sometimes when the wire being bent because of the forces generated by the hard object's foots, that will create a movement in an irrelevant manner. To correct that itself will require another 2-3 months. It is a drawback of the fixed appliance therapy. It can be rolled out. Monthly visits can also be rolled out. And whenever the patient is going to eat, they can remove the appliance. At the same time, there is no restriction on the diet. So those are the advantages. You can enhance the advantages of the aligners over the fixed braces. And only when the patient is willing for the aligners, we can suggest them for an aligner treatment, because it also have to look for the affordability of the treatment. The third question is, who is involved in the fabrication process of the aligners? Do aligner companies or labs consult an orthodontist before manufacturing the trays? Especially only scans or models are provided. Yes, they will consult an orthodontist, and all orthodontic aligners fabrication unit will have an in-house orthodontist who will review all the treatment plans and he will design the plan. Number 2, even after the plan is designed by the orthodontist and sent to us, it is better for us to have a discussion with our own orthodontist to ensure that the plan is right, so as to, if there is any necessary correction, we can communicate with the lab and ensure that the correction is being done. So what steps should be taken if a patient discontinues aligners use or loses a set of aligners mid-treat? The patient discontinues the aligners, we have to insist them to continue with the aligner from the previous set or whichever the set that suits. And if the patient lost the aligner, you can ask the lab to fabricate the set, particular aligner set alone, either in 1 or 2 numbers. We can tell them to refabricate that particular aligner. That is actually chargeable. So moving on to the next question. What should be done during first patient appointment once they are convinced to start the aligner therapy? How can we ensure that they stay committed to the treatment process? Soon after the patient convinced for the aligner therapy, we have to go ahead with the pre-treatment requisites. As I told you earlier, any filling needs to be done that have to be completed, any root canal treatment, followed up with a temporary crown, and a routine scaling, followed up with an intraoral scan. How we can ensure that they stay committed to the treatment processes? Only by motivating. So, last question. How can we effectively monitor and keep track of patients undergoing aligner therapy to ensure compliance and successful progresses? You can use that INVISALIGN progress assessment tool, at least in the patient whom you suspect that they are not wearing the aligner properly, because not in all cases it requires scanning, because the scanning is also chargeable for a doctor who doesn't have the scanner on their own. So in a case, whenever they come for a review, you can check for the aligner fit and movement of the teeth, proper intercuspation. You can check that if the aligners are fitting properly, it is on track. If you doubt that the patient is not wearing the aligner properly, and if you say that, sometimes they will end up in arguments saying that they were wearing it properly, but the system is not working. In those cases, you can go ahead with the progress assessment. You can ensure the position of the teeth with the particular aligner number, and you can match it with the routine treatment plan, and you can exactly tell them where the actual problem comes. It is not about pinpointing them the problem to the patients. Rather, we can find out the solution with the progress assessment tool. Is how, if the particular tooth is not moved, we can step down the aligners. For example, the patient is in 35th aligner now, says that it is not working. After this progress assessment, we can come to a conclusion. The exact problem is from the 18th aligner or 16th aligner. If we go back to that aligner and come back again, this problem will get corrected. That is the solution we can arrive with the help of this progress assessment. It is not about blaming patients. So do the clear aligners truly work as effectively as claimed, and are they a reliable success treatment option in clinical practice? Yes, it is out of practice, it is successful, and being treating so many patients, I can come to a conclusion. If the treatment plan is properly done, it works in a very excellent and effective manner, and it is very fast when compared to the conventional braces, because in conventional braces, as we have 3 stages of treatment, like initial leveling alignment. Soon after the leveling alignment is completed, only then we can go ahead with a space closure and finishing and detailing. Whereas here in the routine aligner therapy itself, the entire teeth, that is 14 to 14, the second molar to second molar will be sliced into individual component. Our treatment progresses from T0, that is start of the treatment, to T1, finish of the treatment. It will be defined into different stages. Each tooth will move individually towards the completion or goals of the treatment. For example, second molar needs to move only 3 millimeters. It will be completed in the 12th aligner itself. So if the patient has 35th aligner, from 12th aligner, this second molar will act as a retention unit. This aligner will just hold the second molar in passive part. So till the 35th aligner, it will avoid the relapse. It will act as a stabilizing unit. Likewise, each tooth will complete this movement earlier. Whereas when it comes to fixed appliance, we have to complete O1-2. For the O1-2 wire to be upgraded, we have to wait for all the teeth, even if it is palatally placed or labially placed, they should come into the arch to complete the tooth movement. Till then, we have to wait, because the rest of the tooth, even then if they have completed the movement, it is not possible for us to upgrade the arch wires, because that is the only drawback with the fixed appliance. So it is definitely going to be a time-consuming process. In that aspect, this clear aligners is very fast compared to the fixed appliance. So moving on to the conclusion, clear aligners provide an aesthetic and comfortable option to conventional fixed mechanics. Obtaining a periodontal health is easier in a patient treated with the clear aligners, and less white spot lesions develops during the treatment. Clear aligners can be used in mild to moderate providing cases, but caution must be exercised in complex cases. You can have a discussion with your orthodontist, and root resorption is still a risk associated with orthodontic treatment, especially in aligner therapy, such as in fixed appliances. Long-term stability studies are required related to its root resorption process. So the key takeaways are clear aligners are effective if the case selection and the treatment planning is appropriate. Digital planning is key to achieve predictable outcomes. The patient complaints directly affects the treatment success that should be accepted and anticipated problem. Retention strategies are essential to maintain and to achieve a desirable results. These are my references. Thank you.
Thank you, doctor. That was an elaborate discussion on aligners. Thank you so much. And it was very informative as well. Any participants, if any doubts, can be asked now. Participants can ask any doubts if they have. You can just unmute your Google Meet and you can talk.
Hello.
Yes, doctor.
Hi, good morning. This is Dr. Hari Krishnan, orthodontist from Chennai. Thanks, Dr. Veerasankar. I was able to join in between. I just want to know what is the toxicity of these aligner materials, because I do material research. So I want to know about the toxicity status now and what is the evidence available.
Yes, sir. Coming to the talk, we have a variety of researches being published about related to the toxicity, sir, comparison of the materials. But when it comes to a clear aligners, it is the material being used, commonly used is PETG and polyurethane, sir. We have a systematic review also, and the published research in PubMed. I have a recent publication. What they state is it is within the applicable limits, sir. It is not at all toxic, sir. We can go ahead with using the aligners.
Right. Okay. That's what the literature shows. Of course, there are a lot of literatures which are not seen by the clinical crowd, comes in other environmental and other toxicity journals. And I have also completed a work which shows quite a lot of highly toxic compounds leaching. And the leaching of these compounds are never mentioned in the other literature, surprisingly, which I have seen. So anyway, I think that will be interesting to see the future of toxic of anything, PET-G, PET-C, polyurethane, and PET-C as well. All the four I have analyzed, all seems to leach quite heavily toxic compounds. But let us see. I think we have to wait and see. We have to weigh the balance between the advantage of cumulative long-term toxicity of the material, where the patient wears it for a longer time. And some journals have shown the amount of microplastics release on the first day of the aligner wear as 3 million per day. So 3 million microplastics following for the patient. We don't know what is the long-term toxicity here.
Yes, sir.
So that will be interesting. Yeah. Okay,
Yes.
thank you very much.
Thank
Yeah.
you. Thank you, sir. Thank you.
Anyone else? Any other doctors, if they have any doubt, can be asked now. Probably later we can take the question later.
Yes, sir. Yes, sir. Sir, actually, already they are working on it, sir. We are planning to set up a unit in China. So it will be easy for them to ship the aligners here. This transit time will be reduced, and it is also cost effective. We are working on it. They have already conducted a survey related to it.
Manikavasam, you want a center in Tirchandur or? I know you are exploring that. Okay, thank you.
Okay. Thank you so much. Thank you, doctor.
Good morning, Dr. Veerasankar.
Good morning, sir.
Yes. I'm a cosmetic. My doctor.
Yes.
What about the tooth discoloration? Depends upon the materials because lot of companies are there. I'm not mentioning about the companies. What is the difference between the companies like INVISALIGN and many more companies are there? What about the result? It will be vary or differ from a company or it will be same. And tooth discoloration is the main keyword I'm asking.
Sir, yes, sir. Yes, sir. Actually, a good point of discussion, sir. When it comes to companies, actually, how I can answer this question is it's not about the company. It is the method of tooth movement that is being incorporated with through the aligners. That is what I am discussing about the mechanics of tooth movement. One is the displacement drive one, the other one is a force driven. So these companies, most of the companies follow the displacement driven mechanics with which we can correct the simple type of tooth movement, or we can achieve the simple type of tooth movement like tipping, minute space closure, minute alignment. Whereas anterior retraction or dislocation or the complex procedures or complex treatment can be achieved only when we follow a force-driven mechanics, which is possible only in certain type of aligners. So it is about the method that is being chosen by the aligners, and also it involves the treatment objectives planned by the clinician to achieve the desired results. Number two, moving on to the tooth discoloration. It is the mainly because this discoloration is because of the attachments or the composite that is being used for the attachments. Also, when we are discussing about the placement of attachments, been mentioning about a point of removing the excess composite around the attachments over the tooth surface. If it is left unremoved, most of the times that might be the reason for discoloration around the tooth surface where the attachments is placed. That is not because of the aligner treatments.
Okay. Is the aligner will compete with the open coil spring, closed coil spring, and all the auxiliaries used in orthodontics? Can it overcome all the things like a deep bite case or overbite overjet case?
Sir, day by day, they're actually improving. But when it comes to the placement of elastics and hooks, it is already there in the aligners with the help of button cuts. This bondable buttons can be placed along with the aligners one. Number two, elastics can also be engaged along with the same aligner therapy. And when it comes to a skeletal anchorage, we can incorporate tabs along with the aligners.
Thanks, sir. Thanks for a wonderful lecture and a wonderful explanation. Thanks.
Thank you,
Thanks.
sir. Thank you, sir.
Hello.
Yes, doctor, you can ask.
Doctor, just a small doubt. Is it like the
Yes.
attachment region only we have a force, or we have a force all over the alignment, and in the attachment we have excess force, doctor?
Yes, sir. We have force all over the aligners. In the attachment region, actually, either we exert excess support, or sometimes we can apply force through the attachments. Both is there. When it comes to an anterior intrusion for deep bite correction, we will take premolar as an anchorage unit. We will use an attachment over the premolars, so that premolars will act as a resistance for that will avoid the anterior intrusion. That will avoid the posterior extrusion, which is a side effects of anterior intrusion with the conventional mechanics that can be avoided by placement of the attachments in the premolar units. That will also help us to go ahead with the proper anterior intrusion. So sometimes this aligners acts as a force application. These attachments can be used to apply forces to the teeth along with the aligners, or sometimes it is used as an anchor unit to gain support.
Okay, thank you so much, doctor. And regarding the proximal
Yes.
stripping, doctor, because
Yes.
I had a case and they just gave me like 0.1, 0.5 of the distal proximal stripping. It should be the perfect 0.1, 0.5 in that region so that the aligner works perfectly.
Yes,
If any discrepancy in the proximal stripping, will there be a discrepancy in the tooth movement also, doctor?
Yes, ma'am. The proper space method, that is IPR, as per the clean check planning, should be given so that the aligner works in an effective manner, even if it is 0.1 or 0.5 millimeters, ma'am. There is a proximal questioning, that is IPR gauge is available, which can be used by us to check whether the space given is between the 0.1 or 0.2 to 0.5 millimeters. And starting with the 0.1, it is actually difficult to achieve this 0.1 millimeter of space with any other modalities. Sometimes you can use a paper strips, that is one-sided proximal strips, that is paper strips, or sometimes double-sided metal strips also help to achieve this 0.1 millimeter of clearance between the tooth surface. But the space should be given so as to achieve the ideal desired results as per our plan.
Okay, thank you so much, doctor. Thank you.
Thank you. Thank you.
Doctors, anyone else who want to ask doubts, please raise a hand and you can unmute and ask. Yeah, I think we can conclude the session here. If any more doubts, you can please ask in the group where we have. You can ask the doubts. It will be answered in a separate way. So no need to worry about anything. In future also, you can ask any doubts related to this, and doctor will be able to answer. Thank you all for joining us today. Hope it was a very informative session. Thank you so much.
Thank you, sir, for giving me this opportunity, sir. Thank you, sir.